It's my pleasure to be here. I'm Ting Bao. I would like to introduce our speaker, Dr. Jun Mao. He's the Chief of Integrative Medicine Service at Memorial Sloan Kettering Cancer Center. He's also the President of the Society for Integrative Oncology. And most importantly, he's a research scientist. His research has been centered on investigating the mechanisms, effects, and integration of complementary and integrative health therapies such as acupuncture, yoga, tai chi, massage, and herbs for symptom management among cancer patients and survivors. So it's our pleasure to hear his talk on the role of oncology acupuncture for cancer patients.
Good morning. It'll be helpful if I'm not on mute. Thank you for participating in the webinar. My talk is the role of oncology acupuncture for cancer patients. Before I start, I want to let all our members, as well as those who are non-members, know we have a very exciting conference for the 2017 SIO conference in Chicago called Person-Centered Care in Integrated Oncology, Innovations, Impact, and Implementation. The call for abstract is open right now. It's due in early May, so I look forward to seeing your submissions. So for today's talk, I will hope you leave with three learning objectives: to learn the basic theory and mechanisms of acupuncture, to learn about clinical research and evidence for oncology acupuncture, and to develop an evidence-based framework to integrate acupuncture for symptom control in cancer patients. So let's begin with talking a little bit about the theory and mechanism by first reviewing that acupuncture is a small part of the larger system of healing called the traditional Chinese medicine, which also include herbs, tuina, massage, diet and supplements, and qigong, more of a sort of mind-body therapy, as well as tai chi, a form of exercise. And this type of practice has been originated over 2,000 years ago with classic textbooks such as Huangdi Neijing, Yellow Emperor's Inner Classic, Nanjing Classic of Difficult Issues. Just like Western medicine, acupuncture has evolved over the millennia with multiple iterations of a change in writing, mechanism, and theories. Certainly today with modern research, we're hopefully to continue this line of updating the science and evidence and theories of acupuncture. Acupuncture in the Western world has been relatively new, but in comparison to Western medicine, it's actually being mentioned quite a while back. Sir William Osler used to be a professor at University of Pennsylvania, the earliest medical school in the United States. He later went to Johns Hopkins and became almost considered the father of modern medicine. And today still there's the Osler service that is given to internal medicine residents who are at Johns Hopkins Teaching Hospital. So even in 1892, he endorsed the use of acupuncture to treat lumbago, also known as low back pain, the sciatica, in his famous textbooks called Principle and Practice Medicine. But over the years, acupuncture in the United States has been largely in Asian immigrant communities. In 1970s, a New York Times reporter, James Reston, received acupuncture anesthesia for post-appendectomy pain during his trip to China during the first official diplomatic trip accompanying President Nixon. So that single event received a lot of press coverage. He experienced a lot of relief in his nausea, vomiting, as well as pain. And as a result, acupuncture became much more of a well-known phenomenon in communities outside of Asian communities. So in 1973, the American Medical Association Council of Scientific Affairs declared acupuncture as an experimental medical device. In 1996, 20 years later, the FDA in the United States reclassified acupuncture needles as Class 2 medical devices is sort of very general classification. Is basically anybody who is qualified to use can use it. So in today's U.S., about 8.2 million or 4% of U.S. adults use acupuncture in their lifetime. And to just put that into context, about 10% of U.S. adults with cancer have used acupuncture in their lifetime. So cancer survivors are using acupuncture at higher rates. And about 1% of American adults use acupuncture in the last 12 months. Between 2002 and 2007, there's about 50% of an increase in the utilization in the U.S. population. And when asked why people use acupuncture, 56% want to combine that with conventional treatments to enhance therapeutic effects. 50% want to try it. And 44%, also a large component, really felt that whatever conventional methods, as physical therapy or pain medication, were not helping. And 24% utilizing acupuncture as recommended by conventional medical professionals. A small proportion used acupuncture because conventional treatment is too expensive. In terms of looking at the biology of acupuncture, there have been numerous research in basic science literature in rodent as well as cat as well as pig models, looking at how acupuncture modulates the biological system. So research has found that acupuncture affects a variety of physiological systems, neuroendocrine, opiate, serotonin, and dopamine in the central nervous system, as well as on the parasympathetic system and sympathetic system regulation. And last but not least, acupuncture has also shown to modulate the hypothalamic pituitary adrenal axis, influence stress and the reproductive hormones. And the most common use of acupuncture in the United States as well as Western world is for pain management. So Professor Han Jishen is an electrophysiologist from Peking University. So even in the early 1970s, he started looking at it with acupuncture stimulation can help release endogenous opiates in brain. And with naloxone blocking, with a type of antagonist of opiate, it blocks analgesic effect of acupuncture. And he particularly focused on different modes of electrostimulation, showing at lower hertz. 2 hertz is basically mimic the manual acupuncture, so it can make the brain release beta endorphin, endomorphin, and enkephalin, targeting the mu and delta receptor at higher frequency of 100 hertz. It can help the spinal cord release dynorphin targeting kappa receptors. In the last 10 years, there have been also robust research in the area of functional brain imaging. So Dr. Claudia Witt's laboratory, Dr. Witt is a board member of SIO, and their group have done, working with international researchers, have done a systematic search of over 700 papers, identified 149 meeting meta-analysis, descriptive analysis, and 34 meeting meta-analysis. This is actually one of the very first study looking at meta-analysis of fMRI findings of including acupuncture, but really make novel contribution to the area of fMRI clinical research. Their conclusion is basically acupuncture does not just stimulate one specific area of the brain, but really encompasses a broad network of regions that consists but not just limited to somatosensory, but importantly, affective cognitive processing. This is quite important because as acupuncturists, we see in the clinic, most time we are asked to treat chronic pain or chronic symptoms. Although it can be very effective in acute setting, but what comes to our clinic are often patients have suffered from months, if not years, of chronic symptoms. So clearly, those affective cognitive processing are really important in both why patients experience benefit, but may in the future can help us predict who may benefit from acupuncture. And clearly, this meta-analysis also identified areas that future research can be conducted to really improve the research methodology as well as the transparency of the research, so we can have a better understanding of the mechanism of acupuncture for symptom management. If we switch our lenses from biomedical way of understanding acupuncture, let's look at what TCM looks at acupuncture, what the theories are. This is actually kind of important because a lot of patients at least come to my clinic, they're very curious about how acupuncture works from a traditional Chinese medicine perspective. So having some basic understanding will help you to have a good communication with your patients. So in Chinese medicine, there's this concept called qi. It's the Chinese character. It's made of, the top part is air, the bottom part is rice. So it's really a substance that circulates in our body. So the most closest way to think about that in Western medicine is the energy, how you feel. So when that energy is flowing through your body in a smooth pattern, you feel the world is great. You feel physically, mental, healthy and calm and relaxed, yet energetic. When that is disturbed, you either have symptoms, you have pain. The diagram on the right is the ancient drawing of the channels in Chinese medicine called meridians. So carry this qi. When this energy is blocked, where you have health problems or pain or symptoms, so by acupuncture, you try to access to those specific points and open the channels, the gates to allow the energy to flow smoothly in those channels. And this is a diagram to show that energy flow in our body from the anterior, from the bottom of the feet through the anterior part of the body, connecting the skin, exit through our hand and circulate to connect with the universe. So Chinese medicine always focuses on looking at the individual's health in connection to its environment, the larger environmental context. And this is an example of the shortest of the meridians called the Shaoyin, a heart meridian, is starting from the axilla and exit through the pinky. And in acupuncture, we not only can place needles, as you can see there, but we can also provide heat stimulation and called moxibustion. It's very commonly used in China, but much lesser used, I would say, in academic acupuncture practice in the United States because of the fire hazards as well as the smell of some of the moxa can mimic marijuana, although with the more medical marijuana going to the mainstream medicine, maybe one day moxibustion will be in our clinic, remain to be seen. But a very common way of using acupuncture in academic oncology acupuncture practices is electroacupuncture, basically connecting some selected acupuncture needles with sort of small tense units to provide electro currents. And a lot of clinical research is actually done using this form of electroacupuncture. So now I'm going to talk a little bit about the clinical evidence and research in the area of oncology acupuncture. Before we do that, let's first look at the complexity of symptoms and pain in cancer. So as we all know that symptoms affecting cancer patients through a variety of trajectory, both active treatment, whether it's getting surgery, chemotherapy, or radiotherapy, or nowadays immunotherapy. And there's a lot of common symptoms like pain, fatigue, and nausea, vomiting. And for those patients entering survivorship, many of the symptoms linger for years. And for those patients with advanced disease entering palliative care as well as hospice, clearly there's many challenging symptoms don't respond to conventional treatments. And many of the symptoms cancer patients experience are also multifactorial, not only related to the disease of cancer, but also related to the treatment as well as psychosocial experience of cancer, whether it's depression, anxiety, of the essential meaning of life and uncertainty or fear of recurrence. And specifically, I think a type of symptoms that are unique to cancer patients is no treatment in current biomedical management of disease are as harsh as the treatment for cancer patients. Surgery, chemotherapy, radiation, target therapy, hormonal treatment, immunotherapy all bring its unique symptom toxicity, whether it's hot flashes, fatigue, and pain. It is really rare to have a biomedical treatment of cancer that doesn't have side effects that really cause a lot of symptoms, may even negatively impact adherence to conventional treatment, let alone decrease quality of life. So our past president, Lorenzo Cohen, as well as Kay Garcia, our SL member, have done a really great systematic review published in 2013 in Journal of Clinical Oncology. In that review, it found clear evidence of acupuncture for chemo-related nausea, vomiting, but there are areas that are very promising, but the research evidence is still quite not quite mature, but are still in the process of being emerged. In the area of cancer pain, AI-related arthralgia, chemo-induced neuropathy, post-operative ileus, xerostomia, hot flash, anxiety, depression, sleep quality, fatigue, and lymphedema. Again, for those clinicians who are in the interface communicating between acupuncture and medical or surgery or radiation oncologists, I think this is an important paper to when you consider about talking with the oncology colleagues. And also importantly, I think Garcia et al. Highlight the limitations of existing studies, such as small sample size, and the comparison groups are used not necessarily answering the appropriate research questions. Some studies are very small, but they claim they're trying to study efficacy when clearly they're underpowered to detect difference between real versus sham acupuncture. And certainly there are blinding issues. There's a lack of assessment of both biological as well as objective outcomes. And many studies use only one acupuncturist. A lot of studies are very short term. One thing is not in the review, but I added is in orange. Is I think a lot of the earlier studies of acupuncture, the interventions are quite problematic. It is getting better, but still, acupuncture does not just mean putting needles. It means putting specific types of needles at specific points, and there's a duration, intensity, and type of stimulation. I think all those things need to be well thought to develop appropriate interventions for appropriate symptoms. I'm just going to highlight a few big papers in this area, so as people try to communicate with your oncology colleagues, those are good papers to consider referencing. Judy Shen from UCLA, as early as in 2000, have published a paper in JAMA showing electroacupuncture has good control for high-dose chemotherapy in women with breast cancer. So they have three groups of electroacupuncture, minimal needling, and just drugs only. So what they found, that the median episodes of vomiting, emesis, also known as emesis, is much reduced in the people who are getting electroacupuncture versus minimal needling versus pharmacotherapy in the first 5 days, which is their primary endpoint. And towards the follow-up period, that effects reduced to non-significant, but you can still see if you look at the absolute numbers. So still, the electroacupuncture group, the emesis is still reduced at a level of 4. So the minimal needling and the pharmacotherapy group, their emesis have decreased, which is follow the normal expected clinical course. So again, this is a graphical representation. Electroacupuncture showed the statistical significance compared to minimal needling in terms of reducing emesis episode, and also minimal also is better than pharmacological therapies. So that's probably why some of the acupressure research also showing is beneficial. So clearly minimal needling has an effect in this setting. And so the conclusion is in patients with breast cancer receiving high-dose chemotherapy, adjunct electroacupuncture was more effective in controlling emesis than minimal needling. So I think this kind of results, although as acupuncturists we know very well, but I still think it's not getting to our medical oncologists to patients. Even as of yesterday, I saw a patient with refractory vomiting and nausea, with 3 months of chronic nausea and vomiting we're seeing in my clinic. And I just wished, the medical oncologist or the patient were aware of this evidence, because if we could implement it early, the patient wouldn't be suffering for those 3 months with 20 pounds of weight loss. So clearly, there's a lot we need to educate our doctors about this, nurses about this type of evidence. And pain is very common in cancer patients. Certainly, this is a lot. There could be a lot of type of pain. This is just one study I'm highlighting. It's done by our past president, Dr. Gary Dang, in collaboration with David Pfister at Memorial Sloan Kettering, as well as Andrew Vickers, one of the earliest funder of SIO, and Barry Caslett, our funding president of SIO. So in this study, they compared acupuncture versus usual care for pain, dysfunction, and xerostomia in patients with head and neck cancer following neck dissection, where they found, compared with usual care, that acupuncture improved basically head and neck functional scores and pain scores, as well as xerostomia scores, and specifically focus on pain. What is interesting about the study, if you look at the blue curve, that is acupuncture. What is intriguing, which also leaves unsettled, is the curve continues to separate. I wish I would know that what happens, say, 12 weeks or 24 weeks from now, because it doesn't seem to me by 6 weeks the effect plateau yet. So clearly we need longer-term study. And in terms of xerostomia, our colleagues at MD Anderson, Dr. Cohen, Kay Garcia, are doing 2 large studies in this population. Certainly we're waiting for their results to see, and they actually have sham/placebo control to see how acupuncture fares against usual care as well as active control. But until that study is done, we can certainly say that significant reductions in pain, dysfunction, and xerostomia were observed in patients who receive acupuncture versus usual care. So because this is a very challenging population, so for those patients who do not have complete relief from conventional methods, whether it's physical therapy or pain medication, clearly we need acupuncture can play a role in managing those very challenging symptoms. And fatigue is one of the very common symptoms cancer patients from various stage experience. And in the largest trial that is done by Malasiotis, they randomized 246 patients in acupuncture versus routine usual care. What they have found is at the end of 6 weeks, acupuncture improved fatigue measured by the multi-dimensional fatigue inventory, and have shown that at least compared with usual care, acupuncture is an effective treatment. So people often say, well, this is good for usual care. How about attention control? So that sham control, later on I will show some of the data from my own research in this area on hot flash. I do think depends on the research question it need to be answered. We can, based on this type of study, we can show that acupuncture is effective, but we cannot conclude that acupuncture, the specific needling, is effective. It may be by the combination of needling as well as patient-provider engagement actively involving patient in care, that complex interaction resulting in a benefit. But what is reassuring that in terms of the treatment, acupuncture appear to compare with usual care, producing a clinically meaningful therapeutic effects. Because of the research, like I mentioned earlier, currently 5 out of 11 NCCN guidelines for supportive care recommend acupuncture for adult cancer pain, cancer-related fatigue, and anti-emesis, as well as palliative care and survivorship. I think these are really important documents that is really put forth by the guidelines from the leading cancer centers in the United States. And I do think as we try to communicate with our conventional colleagues, especially those who are very skeptical about acupuncture, mentioning those guidelines and help us to move from sort of an empirical practice of acupuncture to more of an evidence-based of practice of acupuncture. And another encouraging sign is there's quite a robust growth of oncology acupuncture. So in a study we currently are doing, I'm working with Han-Jun Yun, who is a postdoc in my lab. Comparing with 209, we found that there is a robust 30% growth in NCI designated comprehensive cancer centers in endorsing acupuncture as a symptom management, have increased from 58.6% to 88.9%. Essentially, we can say majority, if not all, NCI designated comprehensive cancer centers have listed on their websites recommending acupuncture as a way of managing symptoms. And also impressively, 73.3% of those cancer centers have acupuncture provided as part of the academic health system. Clearly, acupuncture, I think, is being actually integrated into conventional healthcare delivery system to meet the needs of our cancer patients. So the next portion of the talk, I want to just talk about how we can develop an evidence-based framework to incorporate acupuncture into our care for patients. So evidence-based medicine was initially proposed by Sack et al. In the 1980s. So basically, it's about integration of best available research evidence with our clinical expertise, our patients' values and circumstances. I'm going to use a case of women with breast cancer. Ms. Jones is a 45-year-old woman diagnosed with stage 2 breast cancer with ER-positive cancer. She had surgery, radiation, and chemotherapy. Her menses stopped during chemotherapy. She also had oophorectomy because she had a BRCA mutation. So as a result, she was recommended to start with one type of aromatase inhibitors that will further decrease her production of estrogen in her peripheral tissue. So a patient came to see me. She was complaining, well, doctor, I'm already experiencing 10 to 15 hot flashes every day. I'm waking up 3 to 4 times. I tried venlafaxine, also known as Effexor, an antidepressant for hot flash, but that drug sapped my energy level as well as sex drive. Hot flash was bad enough. Now I have no desire for sex. That just makes me feel worse. She's a teacher. She felt like her passion for work has been robbed by the disabling symptoms, loss of sleep, feeling of exhaustion and irritability, as well as embarrassment when her teenage students see her sweating and flashing in front of the class. They just think she's a crazy woman. That's really her word. On physical exam, her vitals are normal, her lung and the exams are normal, but she was visibly flashing in front during the physicals with a beads of sweat from her face, and she was feeling somewhat embarrassed. So this is a woman clearly needs some options, right? So let's talk about what are the clinical experience. And she's a fairly young age. She had premature menopause, frequent hot flash. She needs additional hormonal treatment as part of the treatment of her breast cancer. And what we know about breast cancer and hot flash is it's very common, debilitating, often induced by premature menopause, such as chemotherapy and oophorectomy. And certainly systematic anti-estrogen therapy, whether it's tamoxifen or aromatase inhibitors, can make the symptoms worse. And survivors with breast cancer tend to have more sleep disturbance, fatigue, and worse quality of life when they have hot flash, and their hot flash tend to persist longer. And interestingly, not only women with breast cancer, but also men with prostate cancer on androgen deprivation therapy can experience hot flashes. In terms of current conventional treatments, estrogen-based therapies are contraindicated in this population. And there are a number of non-pharmacological treatments such as venlafaxine, citalopram, paroxetine, and gabapentin, pregabalin, and clonazepam may all show in short-term trials to be better than placebos. In terms of medication, you can consider use citalopram 10 milligram can show similar outcomes as a higher dose, so lower dose the better, with lower side effects. Unfortunately, gabapentin is 900 milligram daily dosing is more effective than lower dose, so higher dose the better in terms of management for hot flash, but with its increased side effects as well. Venlafaxine, also known as Effexor 75 milligram, is currently considered probably the first line drug therapy for hot flash. 75 milligrams showing similar outcome but less toxicity than higher dose, and also had quicker onset than clonazepam, and showing results similar to gabapentin, but patients tend to prefer venlafaxine. So those are the clinical experience. Then now look at the patient's preference values. So this patient is very hesitant to start AI because she's worried that cancer hormonal drug will make her hot flash worse. She also has experienced side effects with antidepressant as a way of managing her hot flash and worry that she will develop additional toxicity on top of her existing hot flash. So that's not an ideal option for her. She also has increased mood disorders and fatigue and sleep issues. So let's look at about how women make decisions about incorporating acupuncture for hot flash. So I did a qualitative study funded by the American Cancer Society among 25 women with hot flash. About half of them are African Americans, half of them are Caucasians. So we found that a major reason women prefer acupuncture is not necessarily they naturally think acupuncture will be more effective than drugs, but really it's this desire they want something alternative medications. For example, when women said, I hate taking pills, I have enough of them to take as it is. And another person, conceptual herself, as a cancer patient, had been treated by very invasive means such as surgery and chemotherapy. And during the period of survivorship, she really would prefer to have something more natural and doesn't want another foreign object in her body, meaning another chemicals or drugs. And last but not least, one patient, older patient, saying, I'm already taking enough medications. I'm taking 6, 7, 8, 9, 10 pills a day. You know, that's just too many pills. So for that reason, she wouldn't want to add another pill to her regimen. She wants to try some non-drug approach. So clearly, there are patients who are very for treating their hot flash, use more natural approach. So acupuncture can potentially play a role. So let's review the evidence. So in 2015, our group published a paper looking at electroacupuncture versus gabapentin for hot flash among women with breast cancer. And this is a study looking at both the overall effect as well as looking at the magnitude of placebo-nocebo response to acupuncture versus pills. So we did this trial. So there are electroacupuncture group and the sham acupuncture group. Both groups get 10 treatments over 8 weeks. Then the drug groups, they randomized to gabapentin or placebo pills and taken for 8 weeks and then being weaned off. Then all groups will have follow-up, essentially no treatment for 16 weeks and to be followed up at week 24 to determine the long-term durability of the treatment effect. We use a validated hot flash composite score measured by daily diary, use mixed effects longitudinal model. So we randomized 120 participants with a moderate to severe hot flash. Here's the results. So the green line is the electroacupuncture group. So by the end of active treatments, there's a significant time versus interaction, the treatment interaction effect. So showing electroacupuncture produced the best results, followed by the sham acupuncture and the gabapentin group. And all the treatments are more effective than placebo pills. But if you look at the deep blue, that's the sham acupuncture. sham acupuncture in this setting actually produced significantly more reduction in hot flashes than placebo pills. So clearly demonstrate the process acupuncture, which is what I consider as a sham acupuncture, is a very effective treatment compared with the process placebo pill. And what is also intriguing, although not our primary outcome, our secondary outcome is at week 24, essentially 4 months without treatment. The electroacupuncture group is the best group in terms of producing long-term sustained benefit in terms of hot flash reduction, followed by sham acupuncture group, and then placebo pills. And the gabapentin group actually is the worst group. So what it entails is for those people taking active drugs, so basically when you withdraw the drug, the hot flash tend to return, not to the baseline level, but to a large degree. In that setting, it can be even potentially worse than taking a placebo pill. So what it does show is electroacupuncture produced a sustained benefit that is much better than the pill group and much better than taking the placebo pill. And I do think there's a lot of skeptics of acupuncture saying it's all sham acupuncture, all placebo effect. So my typical argument against that, I think as long as we can make patient better, we all agree that's the outcome we try to assume. The danger of placebo effect is the perception that if that is just a temporary effect, patients try to say to please you. But in this setting, we clearly demonstrated electroacupuncture produced a therapeutic effect that is not only significant than the process placebo, but also is endurable. If that's the case, that is a meaningful therapeutic effect can be deployed clinically. And not only that, let's look at the side effects. So gabapentin group, 40% of people, approximately 40% of people experience a type of side effect, followed by the placebo pill group, a electroacupuncture group, and the sham acupuncture group. So clearly, we can see the drug groups tend to have more side effects than the acupuncture group, but clearly also part of that is the nocebo effect related to the patient's perception they're taking a drug. They're probably attributing some of the day-to-day symptoms to the drugs. And very few studies looking at adherence to hot flash management over long term, but anecdotally, very few people continue to take their hot flash drugs over long term because of the side effects. So shortly after our trial published, an Italian group published a larger study with about 190 patients. So in that study, rather looking at the efficacy point, they compare with integrating acupuncture with enhanced self-care versus usual enhanced self-care. Enhanced self-care group essentially giving sort of instructions about managing hot flash, such as some lifestyle behavior approaches, as well as exercise and healthy living. So what they showed is, in a sense, the results are kind of confirming what we found is not only acupuncture showed an improved effect short term, but that effect is very durable at 6 months after the end of the treatment. So clearly, with this piece of research evidence, we can hope to put this piece together, incorporating the clinical experience of managing hot flash using all treatment approaches, incorporating patients' preference and evidence from research. So in the remaining 5 to 10 minutes, I want to just show that for healthcare providers, whether you are doctors, nurses, social workers, working with patients, I think when your patients experiencing symptoms, certainly you should elicit and understand what the symptoms both means physically and emotionally and functionally. And reviewing existing treatment options, both conventional and integrated approaches, including acupuncture. And when there is some level of evidence of acupuncture, as well as the existing approaches are not ideal, you either base on patient's past experience or patient's preference. I think clearly explaining to the patient what are the historical origin, the theories, both biomedical and TCM theory of acupuncture and current clinical evidence will help patients understand how acupuncture can be helpful. I think one important thing is to explain acupuncture is not like a magic therapy. If you look at our study as well as other published study, typically require a series somewhere between 6 to 10 treatments to result in a benefit. So clearly tell patients you need to have some level of commitment, whether that's time or travel or finance commitment, in order for this to be a therapeutic approach that works for you. And last but not least, evaluate patients' preferences as well as their needs. Unfortunately, in many of the states in the United States, acupuncture is not covered by insurance. So have an understanding about acupuncture, about patients' financial needs are very helpful. So at MSK, we have both private acupuncture as well as community acupuncture, which is half of the price of regular acupuncture, trying to accommodate to patients who may have less financial means. And last but not least, establish right kind of referral network, whether it's acupuncturists in your healthcare system or outside who have experience treating with cancer patients who are also interested in communicating back and forth about the needs of that patient. But then schedule regular follow-up to make sure the patient's physical and psychosocial needs are well met. In terms for acupuncturist practice in oncology setting, I really think with the emerging research, this really become a new subspecialty acupuncture practice. Certainly in a conversation with people like leaders also in this field, Dr. Weidong Liu and Dr. Ting Bao and Dr. Kay Garcia. So clearly there is a need to develop a more refined field of specialty oncology acupuncture, because the cancer patients are typically sicker than the healthy community patients that typical community acupuncturists see. They may have thrombocytopenia, like a low platelet, or neutropenia, low white blood cells, to increase their risk for bleeding as well as for infections. They can also have severe sort of dehydration due to vomiting or profuse diarrhea, so they can be hemodynamically unstable. So all those things need to be monitored closely and check laboratory values to make sure safety comes first. And also it is important to have knowledge of conventional cancer care. I think one of the biggest challenges I see in myself trying to develop oncology acupuncture practice at MSK as well as when I was at University of Pennsylvania is many acupuncturists are great acupuncturists, but they know nothing about cancer. They don't know what are the type of current chemotherapies they use. They don't know what are the course of the treatment. And it's very hard to gain the confidence of the patients when you know nothing about conventional cancer care, let alone to convince conventional healthcare providers to refer your patients, therefore building a healthy and robust clinical practice. And third, I think cancer patients experience a lot of psychosocial needs, depends on the trajectory of their cancer diagnosis, treatment, and survivorship. So having an understanding, knowing when you reach the limit of acupuncture, may consider refer them to the psychosocial or psycho-oncology team, and to have a really robust support for the patients are really important. And last but not least, I think communication and referrals are really critical to have a successful business practice for oncology acupuncture. So keep that line of communication open, let the conventional oncology practice know how you have cared for the patients, and the therapeutic effects will help to enhance more appropriate referral to the practice. So at Memorial Sloan Kettering, we have this online course that is just revamped the last few months. So providing acupuncturists in the community with skills and knowledge to treat cancer-related side effects, as well as to sort of teach them about what are some of the current clinical evidence, as well as current scientific understanding about pain and fatigue and hot flash. So the fundamentals of oncology practice acupuncture that is available to acupuncturists. And for those, we have about 400 community acupuncturists have already taken our course, so they can take our more advanced course on clinical research and side effect management. So I also want to say that MD Anderson has this great in-person seminar, as well as Dana-Farber occasionally also have training for oncology acupuncturists, certainly seeking out CEU programs to enhance the experience of treating patients with cancer, as well as increase competency and knowledge in cancer care is very important to allow this new field to emerge and increase our ability to care for patients with cancer. So thank you for your attention. So I'll be happy to take some questions.
Great. So thank you so much, Dr. Mao. And so while waiting for people to type in the questions, I'm just going to ask one question to start. So on your trial, so the one you presented about acupuncture for hot flashes and published in JCO, the sham acupuncture group seems to be doing pretty well with minimum side effects. So is there any research ongoing regarding what kind of patients may respond really well to sham acupuncture versus real acupuncture?
I personally am not aware. I feel like, by the way, this is a great question. I feel like up to now, a lot of the research have been focusing on whether acupuncture is effective. But certainly with more evidence to show acupuncture is effective, then I think the next set of the questions are for whom acupuncture is effective. So trying to predict who may respond to different type of acupuncture. So as acupuncturists, we know there are many different ways to stimulate the needle in our practice. There are the traditional Chinese medicine stimulation trying to get the qi. There's more of a Japanese acupuncture, very light stimulation. Then there's certainly, like I said, electro stimulation, manual stimulation, and thermal stimulation. So I do think there's a lot of unanswered question in what type of stimulation is mostly more optimal for what type of patient and for what type of condition. I think those questions need to be answered.
Great, thank you. And now there are 4 comments / questions coming out. So one basically said, it's from Ramesh Kumar, said, I have a patient with breast cancer with needles in her right now for pain and nausea and vomiting. So good. And then Susan Yaguda just asked a question. In your community acupuncture clinic, what process do you use to assess for safety concerns in oncology patients?
Well, thank you, Susan, for that question. So the way we do at MSK is before patient can become a community acupuncture patient, we assess, we do a private acupuncture new patient session to assess their suitability of being a community patient. There are patients who are very sick, or they have a lot of pain, they need assistance, or they may have advanced lung cancer, have difficulties laying still in certain position or laying down. So those patients are not suitable for community acupuncture. But then you have other patients, say whether it's neuropathy or with hot flash, they can, and their performance status is pretty well, and their laboratory results pretty safe. So those are good oncology community practice patients, and often our community oncology practice can also be used away for maintenance therapy, because a lot of patients initially can benefit from a course of 6 to 10 private sessions. After that, they do pretty well, but they like acupuncture, they want to continue, whether it's every couple of weeks or some even like weekly for a while during the early phase of survivorship. So in those contexts, I think bringing them to a community format may help to decrease the cost.
Great, thank you. And next, Gary Goodman asked, any evidence for neuropathy, specifically chemotherapy-induced?
So I think there are some really encouraging research done by actually Dr. Bao is our treasurer who is moderating this session, as well as Weidong Liu presented. I don't think the paper is published, but the poster discussion was presented at the San Antonio Breast Cancer Symposium, showing that acupuncture produced effect size that are on par or larger than drug effects, say with gabapentin or Cymbalta. So I think the research is currently ongoing at different labs, to my knowledge, but so far I don't think any research has been published in large mainstream journals. So hopefully within the next couple years. But I could say clinically, when we look at why people coming to MSK for acupuncture, a good proportion of them do come for neuropathy. And in my clinical experience, I would say a good proportion will respond, but not everybody will respond.
Great, thank you. And next one, Christian Nasgruber asked, what is the standard acupuncture treatment protocol to alleviate side effects in terms of frequency of visits? If a patient has 12 to 16 weeks of chemo ahead, is a weekly visit recommended or more frequent visits?
This is a really good question. It also depends on the chemo dosing. I think, again, I'm really speaking from an anecdote rather than research evidence. And I think if patients have no financial limits, I think weekly probably is ideal. And if patients have financial challenges, say if they're doing a Q3 week chemo or Q2 week chemo, I try to tell patients to get acupuncture around the time of the chemo, because especially if you look at Julie Shen's paper to show acupuncture can reduce nausea, vomiting by a couple of days. For example, in my clinical practice, there are patients that are going to be on chemo for the rest of their life. They could live for a year, they could live for 2 years. If you can reduce the time of the feeling sick by 30 to 40%, that really is a really beneficial way to increase their quality of life. And then people will feel less sick, then you can encourage them to exercise, to do other things they may enjoy. But I also see in community acupuncturists one patient to see 2 to 3 times a week. I personally think that's overkill, but that's just my own opinion. I do think it's a really good question. We need to figure out a way how to answer. I just think in my experience with oncology patients, because they have so many other medical visits, I think often even doing a trial require people to come twice a week is a challenging issue for many patients.
Great. And then next one is from Emily Brooke. She asked, thank you for a great presentation. Do you think oncology acupuncture is effective in the inpatient setting?
Emily, thanks for this great question. I do think it depends on for what symptoms, for what condition. I feel if you look at the literature of oncology acupuncture, for acute post-operative pain, if you have a large inpatient service that require like staying in the hospital a day or two after surgery, but a lot of the surgery are now moving to the outpatient setting. So, but if you have some inpatient stays, that may be a good area to target. But we all know that acupuncture often works by a series of treatments. So if patients nowadays, inpatient admissions are fairly short. If patient only admitted for 2 or 3 days, in that setting, if there's a lot of chaos, I'm questioning the value. With that said, I want to just let you know, Dr. Gary Ding, one of our faculty in MSK, he's a past president for SIO. He just finished a study on acupuncture for symptom reduction in people going through bone marrow transplant with really exciting preliminary studies, because those patients will have a defined number of days, stay in the hospital, are often very symptomatic in terms of nausea, decreased appetite, pain. So I think that's a good setting to really trying to answer some of those questions. But again, maybe we have some colleagues in other parts of the country, like for example in China, people still are admitted for chemotherapy or doing that in an inpatient setting. For those people who have a more prolonged course of a hospital stay, I do think acupuncture probably will produce some more meaningful effect.
Great. And then one more is from Jody McLeod. Are there any reason why acupuncture would not be effective in a cancer patient?
Oh, absolutely. I think that's a terrific question. I think I feel like I can give you an example that I don't think acupuncture will at least be effective by itself. So I have treated a number of women with breast cancer for they try to lose weight. But some of the women are really challenging in terms of they don't necessarily want to change their dietary habit. I can tell you without their motivating to change their dietary habit, I don't think acupuncture by itself can cause women to lose weight. So I stopped even accepting those patients unless they are committed to, lifestyle change, because I personally don't believe acupuncture is really magic. And also, sometimes you will have patients who say, "Doc, can acupuncture to make me live longer?" Unfortunately, currently there's no such evidence, and I don't think we can say that to patients with advanced disease. What we probably can say is, if you find we can help you to manage your nausea, vomiting, to help you to improve your quality of life as a result, you can be tolerating the conventional chemotherapy or hormonal treatment you're getting, there's going to be a net benefit for your survival. But by itself, acupuncture is probably unlikely to increase survival.
Great. The last question is from Rachel Mendenzo Aponte. She's asking, in your experience, there's any contraindication in some specific type of cancer and acupuncture?
This is really a good question. I think as a field of oncology acupuncture, we keep pushing the envelope. I think by some great work from Elena Lada's group and Cara Kelly's group in Columbia, even for people with neutropenia, as long as you have laboratory results, you modify the treatment, you can still do acupuncture for patients with fairly low platelet and a low white count if you're doing it safely. But I would say in a community setting, when you don't have access to laboratory results, I think it's really critical to be careful. Ask patients for those values. I have plenty of patients on Coumadin, so I often ask, when is your last INR check? Because if they say, one of the patients I've seen, they had like INR, like for some reason that visit was like 6, 7. So for that visit, you definitely don't want to do deep tissue needling with electrostimulation. You may just get a big bruise that will make the pain worse. I also think because cancer patients, pain doesn't just mean it's a physical pain, often can represent metastases or recurrence of their disease. I had a few patients with, say, breast cancer come to see me, "Oh, doctor, I have this new pain. I coughed, I feel like I break my ribs." So instead of doing acupuncture, I send them to X-ray, and actually found they end up, unfortunately, having bony metastases. So in those settings, I think if you just treat that as pain, it can be a really dangerous situation both for the patient and for your medical practice. So you have to be careful.
Great. I think that concludes this session. Thanks.
Great. Thank you very much. Please join SI.
Thank you again for your participation in this installment of our Society for Integrative Oncology webinar series. Early next week, a recording of this webinar will be available on the members-only section of the Society for Integrative Oncology website. This concludes today's presentation. Thank you again for joining us.